A very warm good evening to everybody, and welcome to the first interventional meet of 2026. This promises to be a very interesting topic today. We have a topic of a complex PCI and ostial left main lesion with a patient with severe LV dysfunction. It will be presented. Our speaker for the evening is Dr. Rashi Khare. Dr. Rashi Khare is Additional Director of Cardiology at Fortis Hospital, Shalimar Bagh. And we have two excellent discussants with us. Dr. Neelam Kaul, she's Senior Consultant Cardiologist, Amandeep Hospital, Pathankot. And she's joined by Dr. Seema Naxain, who is Consultant Intervention Cardiologist at Ashoka Medicover Hospital at Nashik. And we have an amazing expert panel with us. We have Dr. Sujata Viparla, who is Director of Cardiology at Indus Hospitals, Visakhapatnam, and our chairperson of our Vincas organization. And she's joined by Dr. Asha Mahilmaran, who's Senior Intervention Cardiologist at Apollo Hospital, Chennai, and Dr. Gyanti R.B. Singh, who's Director and Head of Cardiology Intervention at Sarvodaya Hospital, Greater Noida West. So without any further delay today, we will start with our presentation of the evening by Dr. Rashi Khare. Dr. Rashi, please share your screen.
Yeah, thank you, madam, for the kind introduction. And I'm happy to have so many experts for my case. I like to be wiser. Just my screen. So is my screen visible?
Your screen is visible, but you'll have to go to your first slide and go on slideshow.
Yeah, ma'am, sure. I'll do that. So I hope I'm visible.
Yes,
right?
Absolutely.
Okay. Yeah. So, sorry. Yeah. So this is a calcified ostial LMC. I'm audible, madam?
Yes, you're audible.
Okay, so this is a calcified ostial LMCA lesion in an octogenarian with severe LV dysfunction. So is the basic case description. He was an 87-year-old male, post PTCA to RCA around 10 years back. He's a case of CKD, but not dependent on hemodialysis. He presented to me with CHB, with a history of angina on exertion since the past 6 months. Echo showed EF of 20%. The troponin was negative. Creatinine was 2.1. So looking at CHB with a heart rate of around 36-40, we did an emergency TPI. Now we had to proceed for PPI or AICD basically. So in view of LV dysfunction, the patient was taken for CAG before going ahead with the AICD. So this is the angiogram. We can see an ostial left main lesion that is around 80%. As soon as we hooked the catheter, the pressure damped significantly, so we had to take a non-selective injection only. There was calcification with a lesion in the mid-LAD as well. You can see calcium, you can see the mid-LAD lesion in this view. The diagonal was also diseased. There was an RI that was significantly diseased, around 99%. LCX had some plaquing, more or less normal. This was the RCA stent. It was patent with disease in the PLV, and it was a big PLV. Limited shoots were taken in view of CKD. So this was the lesions. Ostial LMCA was around 80%. Calcified mid-LAD lesion was there. PLV we have got, RI was there, and the patient is having an EF of 20% with the age of 87 years with CKD. Now I'd like to gain some wisdom from all of us. How do we go ahead now?
This is a very interesting situation. You have a very elderly gentleman. He's got issues with CKD, and his creatinine is 2.1, not on dialysis. EF is 20%. He's already had an angioplasty to the RCA, which is fine. Now you have an ostial left main disease. You have a RI disease, which is very tight. You have a mid-LAD disease, which is very tight. And also you have calcification. So at this point, we'll first ask the discussants one by one what they would do. Then we'll ask the experts. So first we'll go to Dr. Neelam Kaul. What would you like to do in this situation? It's a beautiful case.
So what were the hemodynamics?
The patient was stable apart from having a CHP of rate of 25 to 30. He was on beta blockers, but that had to be given in later also. So the
Okay.
hemodynamics was fine. The BP was around 100, 106 or something. There was no issue with the hemodynamics.
Okay, so since it's a tight left main and there's a lesion in downstream LAD also,
Yeah.
so I would like to if put the patient on low dose inotropes and see if hemodynamics are stable. And I would like to go for since it's a very calcified lesion. So circulatory support can be thought of at this point of time also, since ejection fraction is very low, it's hardly 20%. So I would like to tackle LAD first.
Yeah,
Maybe, and we can go for an atherectomy of the osteal lesion.
Yeah,
And
definitely. I think that's
Would
the
you like
correct
to
approach.
image at this point? First of all, would you like to image? Because
Yeah.
everything will be decided by the imaging.
yes, ma'am. I think imaging is the primary thing which we should do if available in the center. We should do imaging of LAD and know the disease and the extent of disease, the morphology, as well as the extent of left main involvement. Because angiographically it's just ostium, but the disease may extend into the shaft also. So imaging is a good option. We should do imaging first before
Dr.
proceeding
Seema,
further.
what are your comments about this, the
And
case?
now, yeah, here patient has presented with complete heart block, and I think it's a degenerative CHB. I don't think because the RCA is patent, yeah, there is a lesion in ramus, but this CHB is not related to ischemia. So, because and if we perform PCI first, patient will
Yeah,
be on
because
DAPT.
trop is also negative. Troponins are negative.
Troponins are negative, so it's a kind of
Yeah.
stable CAD with
Yeah.
LV dysfunction, not an ACS. So, and if we do the PTCF first, then patient will be on DAPT, and then we'll have that headache of managing. We have to do the permanent pacemaker. So,
Beta blockers, I think.
beta, but still, I think it's a
Beta blockers need to be given in this patient anyhow, whether he's having CHB or not, because he is a case of very high risk. He can be having VTVF anytime. EF is just 20%.
I
Maybe
think he
I will
was on beta blockers.
Yes,
That could
he was
lead
on
to
beta blockers.
heart block also
But-
in
But madam, we cannot
octogenarian.
stop beta blockers in this patient. We need to pace him and then continue with the beta blockers.
And beta blockers, usually you have an underlying degenerative disease of the conduction
Yeah.
system. Beta
Yeah,
blockers will
definitely.
exaggerate that. So it is a degenerative CHB which will require permanent pacemaker. And
Yeah.
because he has presented as a CHB, no ACS, drop or negative, it's a CKD
No.
with calcified TVD with LV dysfunction. I might think of doing a permanent pacemaker first and then followed by the revascularization so that this DAPT management of the surgical wound of permanent pacemaker becomes easy. Because otherwise I have to think of a leadless pacemaker. Then if I do the PCI first and then I have to do the permanent pacing, then leadless pacemaker becomes an option. So we have to think here that whether degenerative CHB should be tackled, and while he is in the hospital, maybe after the first 72 hours, once the wound is okay, hemostasis looks good, you proceed with a proper elective impella, protected PCI with rotablation to the left main and LAD, because it's a planned complex chip case. So
The point is, at this point, Dr. Seema, this patient anyways with an ejection fraction of 20% post-MI patient is class 1 indication for an AICD anyways. So this patient will definitely receive AICD and AICD will give him the backup pacing also. So I think that point we are clear about, that this patient will receive an AICD.
Yeah,
Now,
right.
so there are two very important things that Dr. Seema has raised. One, she has raised the point that should we do the pacemaker first and then the PCI next? So now that point is also to be tackled. Would you like to do because Dr. Rashi has put in a temporary pacemaker already. Now the question is whether she's going to go for the chip procedure first or she's going to go for the permanent pacemaker, because the question of DAPT also comes in at this point.
Yeah.
And imaging, definitely, I think all of us on this panel will want to do. Let's hear what the experts say. Dr. Sujata?
Yeah, Seema has raised an interesting point that
We lost your voice.
timing of the ICD. I would like to do the ICD. You can hear me?
Yes, now we can hear you.
Yes, ma'am.
Yeah, I want to do the ICD first.
Yeah.
Yeah, preferably dual chamber ICD, because you want to do a pacing also. And the other thing, then I would like to proceed with the PCI. I would want to do a right heart cath before the procedure. I want to assess the PA pressures, and if my PA pressures and RV pressures are okay, I would think of just going ahead and image the left main. I'll just put one IVUS catheter, just see what it is, whether I need to do any calcium modification quickly. I'll get an idea of the area of the left main. Does it need intervention? Because Rashi was telling that it was damping, but to me, on looking, it doesn't look so tight. Maybe a particular angle it was damping. So it's always better to look at the areas by IVUS and then assess the calcium and then plan the PTCA accordingly. So right heart cath followed by to assess the support and then the calcium modification strategy by imaging.
So now we have more interesting observations. We'll go to our next expert, Dr. Asha. Dr. Asha Mahilmaran.
Yeah, I think the presentation, I agree with Seema. The presentation is complete ad block. There's no doubt that at this index procedure, he has to receive an AACD with backup bradycardia pacing. Whether we can do a conduction system pacing in view of very severe LV dysfunction, the patient is hemodynamically stable, maybe a conduction system pacing should be considered in this elderly gentleman. The next is, of course, as Dr. Sujata said, a right heart to know the cardiac index so that you can decide on your CHIP PCI what support you need, whether you can go ahead with an IABP or you can you need an Impella, can be decided upon. And then you have to have an IVUS definitely, which will also decrease the contrast load, and the PCI optimization can also be done. And if it's a calcium modification strategy, I would favor an IVL over ahead of the others because of less slow flow and low flow problems. Tolerability will be much better. So that will be the kind of strategies I would consider. Basically, I would go for it at least 1 month after the index procedure.
So very interesting points raised by you, Dr. Asha. And but the question is, when you mentioned that you would want to go with an IVL, IVL would be a wonderful choice for the left main. But considering the situation of the mid-LAD, the mid-LAD appears to be a very tight lesion. What about if we can't get the, there will be a size discrepancy in the IVL balloon, which we will require for the LAD and for the ostial left main. And in addition to that, the mid-LAD lesion is very tight. So we might have a tough situation trying to get that bulky IVL balloon in. But on the other hand, we also have to think that if we take ROTA, will ROTA do justice to the ostial left main? It will do justice to mid-LAD. But will it do justice to the ostial left main? Then comes the question of the orbital. Orbital will do justice to both. It will do justice to the ostial and also to the mid-LAD lesions. So I think all of these things we'll be able to decide once we do imaging. And definitely Dr. Sujata and Dr. Asha brought up the point that IVUS would be good because this is a patient with CKD. So we definitely want to reduce the contrast load because the patient is still not on dialysis. And we want to avoid pushing him towards dialysis at 87 years of age. We have our last expert of the evening, Dr. Gyanti. What are your comments? Dr. Gyanti, are you there?
Yeah, she has joined.
She has joined, I can see, but she's on mute.
No,
okay.
I have unmuted.
Yes, Dr. Gyanti, how would you approach this
I
case?
agreed with that. The first tackle with this, what Dr. Seema and Dr. Asha had raised. First AICD, then followed by PCI with imaging, and this, or as Dr. Sarita said, orbital will be better in this case.
Okay, so I can see that Dr. Jyotsna madam has joined. Dr. Jyotsna ma'am, what would you like to say some comments, ma'am?
Ma'am is on mute.
Ma'am is on mute. Jyotsna ma'am, we can't hear you. You're on mute.
Sorry. The final decision is ASCD followed by the coronary intervention. But I wanted to bring a point. We wanted then ASCD then before the intervention, mainly because of the DAPT then effect. But with the leadless pacemaker, which is already available with an ASCD also, probably this problem of the antiplatelet effect may not be there. So if the patient can afford, yes, we can discuss about the leadless ASCD, the pacemaker, and then do the intervention within a short time. As all said and done, because the patient is on the temporary pacemaker now, it is worth doing a very 8 hours or 12 hours recording of the Holter to know the severity of the underlying the disease, not for the decision making of the ASCD, mainly because we should know that what is the burden of the ventricular arrhythmias in this, and subsequently whether ASCD induced problem subsequently, all those things we'll miss it. So we can have a short run of the Holter if we have the time. That's what my comments.
So very interesting points raised by Dr. Jyotsna ma'am. So cost considerations of this patient also is very important, what this patient can afford, because in every way it's going to be an expensive situation. Now we've heard from the entire house all the aspects, and now we'll go over to Dr. Rashi to see how she handled the case.
So, thank you, madam. It was a very enlightening discussion. So the points to discuss were definitely, because it was a degenerative CHP, whether to go for AICD first, because definitely we had to go ahead with the AICD. There was no use of putting a PPI in this patient. Secondly, do we need to revascularize? So, and if we revascularize, what will be the debulking device we'll be using? There are various options we can think of: scoring balloon, cutting balloon, then rotablation, then orbital. Some people might think of ECLA and even IVL. So I'll just share what I did. So it is a calcified ostial LMCA PTCA that I did with an IVL with an octogenarian with severe LV dysfunction. So I showed the CAG. Ostial LMCA was 80%, mid-LAD 90%, heavily calcified. RI was 90%, PLV was 90%. There was a patent stent in the RCA. So definitely it was not an emergency because the patient presented with CHB. Definitely he had history of angina, but the EF also 20%. So we need to discuss it with the heart team, the intervention cardiologist, surgeon, and the anesthetist, the cardiac anesthetist. So in the team, we decided, as the patient was dependent on TPI, we decided to pace the patient first, followed by revascularization. So I did the AICD of the patient and discharged him after 2 days. Then PET scan was done to show the viability. And PET scan showed viability in the LAD as well as the inferior territory. So again, the surgeon was came into picture. The patient was referred, but the surgeon refused, giving the age, creatinine levels. So patient was planned with LMCA to LAD with IVL. So this case basically, just like we were talking about whether we would do ROTA in this patient, what Justice ROTA will do, because definitely mid-LAD lesion is very tight and it seems that IVL may not cross. So when I planned the case, basically it was a totally cash patient. They already paid for the AICD and they were very, they had to force themselves to spend so much for an 87-year-old patient. But I told them I'll be trying for the IVL balloon. If the balloon does not cross, then I'll be definitely switching off to ROTA maybe for the mid-LAD lesion and IVL for the ostial LMCA lesion. So the safety profile was definitely, IVL was good for this high-risk patient. So I took an IABP because definitely there was a cost constraint. LAD, L6 both wired. The only negative point that I have in this patient is that I could not do imaging because of the cost constraint. It was very tight. I actually made stents also, FOC I had to do. So LAD and L6 were wired, pre-dilated by 2.5. The LAD was dilated, 2.5 millimeter balloon. Then IVL balloon that I took was 3 into 12 millimeter balloon. I only took a single balloon because of definitely the cost constraint. 8 pulses were delivered, 3 in the LAD and 5 in the LMCA. After that, 3 into 38 millimeters DES was deployed in the mid-LAD and 4 into 22 stent was deployed in the LMC LED to the ostial LMCA. And I could actually get a very beautiful stent expansion. We can see the stent placement here. AICD has already been done. And we can see the stent, actually, you will see in this scene how the stent actually opens beautifully in this patient. Now the stent has opened. It has fully opened. After PD, it is not fully open stent. Post-dilatation was done with a 4.5 millimeter NC balloon in ostial LMCA with 20 ATM. And this is the result. The stent was well opposed. Subsequently, distal RCA, the PLV1, I did a DEP, and PTCA LCA, it is not LCA, it is RI, was done in a span of 3 months, keeping a check of creatinine. Now the patient, this case I did around 2 years back. The patient is on regular follow-up. EF has risen about 44%. He is NYHA1, although he walks just around 1 kilometers daily. Creatinine is 2.5, and he is still not dependent on hemodialysis. So in conclusion, what I'll say that LMCA, ostial LMCA is definitely a very complex situation. Sylvia LV junction will definitely add to the burden. IVL is a modality that is ideal for such scenario because of a high safety profile, provided we can actually deploy the balloon to the distal lesion. Balloon sizing and proper pulse dispersion is very important, and proper bed preparation with good predilation is important for ideal IVL results. Thank you.
Thank you, Dr. Rashi. That was a very elegantly performed case, albeit certain points that we wanted to ask you about. Your end result was beautiful. The fact that you staged the procedure to prevent excessive load on the kidneys of the patient was also very appreciable. And you used a combination of rotatripsy, which is so basically you didn't use a combination. You used
I did.
You used IVL for both the lesions. Now this is where the question comes. The question is that your mid LAD was a 3.0, but your left main was a 4 or a 4.5. If you use a 3.0 IVL balloon, the basic mechanism of the IVL balloon is that if you are not in contact with the vessel, it will not work. So if you have a left main which is a 4 or a 4.5, then you need a 4 or a 4.5 IVL balloon in left main for it to work. So your 3.0 balloon cannot work in both these places. So what is your answer to that point?
Ma'am, that is definitely the point. But basically, I had to break the ostial LMCA calcium. That was actually very tight. That was definitely around 1 to 1.5 millimeters. And I could not afford a second balloon. So I had to use the same balloon. Either I used just the scoring or a cutting balloon there, or I used the QK, because mid LAD will not give up before IVL or rota without that. So that is why I simply used a single balloon for both the lesions.
So we are in luck that because it worked definitely on the mid LAD, that was huge calcium over there. And ostial, I think, would have had less calcium, which is why it broke up. But we had a good result. Ultimately, the end result is what matters.
Ma'am, that is why I showed that the stent expanded beautifully. That was the point, was because I was like, if the stent doesn't expand now, I cannot afford a second balloon, but the stent expanded nicely. The ostial LMCA, it expanded nicely.
So congratulations, Dr. Rashi, for a great case. We'll go over to the discussants. Dr. Seema?
Yeah. Ma'am, is it that when that LMCA was so tight and the predilatation was just done with 2.5 millimeter balloon, the LMCA was not totally opened, and that IVL balloon contacted whatever that lesion, calcified lesion was there. So maybe an undersized IVL balloon has worked, because that time the LMCA was not, completely open vessel, and it had a small luminal diameter, and the IVL balloon touched that small lumen diameter with that calcified tight lesion, and it simply broke some calcium, and then later on. This was rather a new thing to learn, that maybe in a very, very tight lesion, a slightly undersized, due to cost constraint, even a slightly undersized balloon has worked, because the lumen area of the LMCA must be very, very low.
Actually, that is a very, what we do when the patient can't afford 2 balloons, we take an oversize. The catch in is, in fact, there are some now publications about it also. You
Mhm.
take an oversized IVL balloon, you
Mhm.
don't inflate it to 4.
Mm.
You inflate it to 2 or you inflate it to 3. You just need to establish contact and you deliver the pulses. And then you take it to the other side where you need the larger size. There you inflate it to 4 and you give the pulses. So what we are now doing is taking an oversized IVL balloon rather than an undersized IVL balloon. This is how the change in concept which has happened. But you just don't inflate it very high. You inflate it to 2 and you can give the pulses. And you actually get better results with that. So there's I forget the name of the doctor in UK who's got a whole series of patients in which he's used oversized IVL balloons just on this principle of contact. But thank you, very good point. And that's one of the ways in which we can make one balloon last, because in our country, the patient pays and cost is always a consideration. So Dr. Neelam, your comments? Dr. Neelam Kaul?
A very beautifully done case, Dr. Rashi, and the end result was very good. There was improvement in LV dysfunction also. That's a very big thing for the patient. So, ma'am, just a thought that instead of using an IVL balloon of in mid LAD, could it cutting balloon be or scored balloon be used in mid LAD, and then the bigger size IVL be used in the left main?
Because it was a planned and elective case, I actually searched for all the options that I could give to this patient. But I thought that maybe IVL were also not close to mid LAD. I was not sure that my IVL, I was like, I had already counseled the attendant that maybe I'll have to do rota, but they were very cost constrained, and luckily my IVL balloon crossed. So it was done with a single balloon.
Actually, Dr. Neelam, in this case, she has not imaged. Now, had she imaged, she would have known whether she could have got away with the cutting balloon only also. Also, whenever you're trying to use IVL and if there are cost constraints, you can definitely try with a cutting balloon, because an Oxford cutting balloon is always there on the table. So a cutting balloon can always be tried as a low-cost option for our patients. When cost is an option, we definitely try with the cutting balloon and it gives us beautiful results. That is also a good option. Dr. Asha?
Yeah, I do agree with Sarita. If your 2.5 balloon tracks, then many a times the cutting balloon can reach. And if your cutting balloon doesn't work, you can always go back to IVL. And sometimes, like she said, taking a slightly oversized, maybe a 3.5 IVL, and then you could have dilated it in the mid LAD as well and got away with it. But you got the result finally. It was very good that you did a PET scan viability and showed that you were doing the right thing. So that was excellent. You did a PET scan viability before you took the case. So I think it was very properly staged, evaluated, and done wonderfully. And proof of the pudding is in the eating. The patient is doing well and walking, and that's great. And his creatinine has not gone up. That is extremely great. Excellent result. You did not choose to do IVAS, or what was you did IVAS because you didn't show the images.
Ma'am, there was a severe cost constraint because this was a very, very expensive procedure. The AICD was done, and then IVL balloon and the stents. So imaging we could not do. We should have done definitely. Left main PTCA mandates imaging in every case, but I could not do it in this case.
We do have a backup of used IVAS catheters, which we do use in cost-constrained situations. Sometimes you can even waive off the charges. You don't show it in the billing, but you just do it, take a run, and then finish it off. That can be done, but I don't know the policy of your hospital.
Actually,
that's what we do. That's what we do. We just take a run, but we don't give a report, and we just tell that IVAS optimization was done one sentence, and then leave it at that. So that we do not, the patient is not charged. Reused IVAS catheters are always available.
So exactly same point I was going to say, Dr. Rashi. Oxford IVUS catheters, we always keep them around because exactly of situations like this, there are many patients who have cost constraints. But the point is we can't give the best results sometimes unless we image, especially in left main. So Oxford IVUS catheters are a go-to in such situations, especially with cost constraint. But again, we don't know. Each hospital has their own policies. So Dr. Asha and I work at Apollo. So it's easier for us, I think, in that situation. Dr. Sujata, Dr. Sujata, best situation. She owns the hospital and the cath lab and the equipment. So she has no problem.
So I definitely would have imaged one thing, as they were saying, I would have just pushed one. It's very easy to push an Oxford IVUS catheter. Just look at it. Maybe you wouldn't have used the IVL. Maybe, and also the interesting thing was, I thought maybe we could just do the left main ostium. Just do the left main ostium and the LAD mid without overlapping both stents. Maybe we could have looked at the landing zones. These are the things which came to my mind. But as Asha said, the proof of the pudding is in the eating. The patient is very good and you staged it very well. I'm very happy with the viability which you did. The other question I had was, now that your EF has improved to 44%, is the ICD at all necessary in that patient? That was what I got because he went above our cutoff of EF cutoff of 35%. So
Ma'am, anyways, he was a candidate for pacemaker. So
yeah,
anyway, the AICD is there to stay.
I got it. You showed the EF was 44. So is this obsolete? That's what I felt. Right?
Yeah.
Great job, Rashi.
I think it's working now as a pacemaker, and in the event he has any kind of a VT or a scar VT or whatever.
Yeah.
Right. Yeah.
Oh, and
He's dependent on pacemaker, madam. He's PPI dependent, right?
Yeah. So that is no doubt. So the pacemaker is half the cost of ICD, no? So that's what I was.
Yeah.
But 20% EF, you can't go back and revise the
yeah.
as well. So you need to take a call.
No. I also would have done the ICD, but that was the thought which came to my mind. So it was well done, no? The viability part, I'm pretty impressed.
I'm really, before showing this case, I knew the imaging question is going to come. And I know this is mandatory in any left main case, but we could not do imaging. That's a loophole in this case.
The other thing, you would have used that 3.5 IVL more rather than a 3 IVL. Definitely, we would have all gone for a 3.5 IVL.
Yeah,
When your stent was expanding, it expanded with a lot of difficulty. In the middle, you can see the constriction. So you're not very sure whether it expanded fully or partially. We cannot be very sure. It looks okay on angiogram. How it look on imaging, we're not very sure. But it did expand with a lot of difficulty, which means
it expanded quite late.
Was a little inadequate. That's what
there was a waste over there. And also, if we had imaged post procedure, we would have been able to see exactly what we had achieved. And so that is also there. Also, if you had imaged, maybe we would have got away without using the costly IVL balloon. That is also a point. So even Oxford imaging does wonders. But see, I always believe that the operator does what he thinks best for the patient at that point.
Yeah.
She did what was best for the patient at that point, and I appreciate 87-year-old gentleman, 20% EF, CHB, creatinine 2.1. When retrospectively we discuss because there's so many learning points in each case.
Yeah.
She did a great
better for the next case. Rashi, I would also have done the right heart cath before putting
that is a learning point for me.
Yeah.
I'm not doing it routinely, but definitely I'll keep that in mind in future.
LV dysfunction. Supposing your PA pressures are not very high, your RA pressures are not high, maybe you could have got away without an IABP.
Mm-hmm.
All these things could have helped you bring the cost of your procedure down, right?
Yes, especially when the patient has an AICD in already. many a times you don't need to put the IABP in such patients because these are chronic lesions and they tolerate ischemia very well. That's also a point. So what we normally do is we take an access and we keep it ready. If we require, we'll insert the IBP. Otherwise, we don't. We just keep it on a backup. So that's another cost-saving thing that we do. So we have comment from Dr. Gyanti and then final comments from Dr. Jyotsna ma'am. Dr.
Would
Gyanti.
you permit me a comment, ma'am? Can I ask a question? If you permit.
Yes, Dr. Shiva.
I mean, congratulations. I've really been enjoying the entire case. And as you said, operator does the best for the patient. And that's what I was thinking throughout when she said, so what happens at that point of time is a nick. But I really enjoyed Jyotsna ma'am's comment. She has actually mentioned about, the leadless ICD pacemaker. And I really do. So anyone who has experience and what is, how it works, and I'm not really aware. Leadless, of course, dual, single. So
I also learned on this.
Yeah, I mean, so I was really
because I've been doing micro. I've done at least 10 to 15 leadless pacemakers, but I haven't heard also that there's a leadless AICD available.
AICDs, yeah. So I mean, maybe ma'am can only tell us more about it. Yeah.
No, I was not aware of a leadless AICD till now.
So I've been imagining since then that what was the modus operandi and how they work, and it's really because otherwise we know how the other pacemakers work and give us the ICD coil and the shock and the SVC, but how this leadless must be working is really very new to me. So maybe we'll have comments from ma'am only.
It is available in India as yet. I don't think so, but Jyotsna ma'am will be able to tell us. Ma'am?
Ma'am is there.
Yeah, I am there. Yeah, it is first a few comments on about the Holter. That's why I insisted on a short Holter recording of the 12 hours because I expected that revascularization will improve the LV function. So to prevent the contradiction only, I wanted the Holter before. Not only the ASCD related problems to know about it, but to know the another indication for the definite for the ASCD implantation. And ASCD implantation recently, I have seen a leadless ASCD implantation in Hazara group mentioning about it can be done in India. But whether it is already freely available or not, I don't know. But definitely literature search says that ASCD leadless pacemaker is available. In the leadless pacemaker, both the delivery and the detection will be at the same point of the implant. So it is not a problem. At the time of the delivery of the shock, it doesn't work as a receiver. So immediately after the shock to the delivery, it will cause the tracing of whether it is converted or not. So the leadless pacemaker of ASCD is quite available. But I don't know which company is able to do it. But I saw that is in the Hazara's group mentioning about this. That's the reason why I got an idea. Otherwise, I have not used it directly.
But it was so good that you are so updated, and it's interesting to know that delivery and detection is at the same point. Thanks, ma'am. We'll now go and read and learn more about it. Thank you.
I will learn about it. And another point is when ASCD is there, to do the right heart cath is a little bit difficult because when you're manipulating and that too recently done lead, you may dislodge it. So another better method and easier one is go for an LVDP. Any severe LV dysfunction, if you're not able to do the right heart cath, see the LVDP. That gives then a lot of information for us. If the LVDP is not elevated, even in the severe LV dysfunction, we need not to worry about it. And if it is required, in between also you can see it, the LVDPs, so that if the procedure may require any support, like Sujata was mentioning, IABP can be then avoided if you know about all those things, can be tested by just knowing the LVDP. And of course, the case result is an excellent.
I would like to ask the panel, would we have just done the ostium and the mid separately instead of having 2 stents and 1 stent across the bifurcation?
I think, Dr. Sujata, you want to ask that 2 separate
Actually, you're muted.
Leave
Yeah,
a zone
yeah.
in between.
Rashi, you're muted. Unmute yourself.
Yeah. I'm saying, ma'am, there was no landing zone, normal landing zone in between the left main to mid LED lesion. We
Okay.
had to put the stents overlapping only.
Okay, then.
No,
Right.
so if you put overlapping stents, what did you do to the ramus intermedius? Did you open that before?
No. I did not do anything apart from doing the left main to LED in that setting. Later on, I did DEB to RI and DEB to PLV.
So
Did
you
you
went
wire
through
the
the stent
Rebus
to the
intermedius
ramus?
during
How
procedure?
did you access it?
Ma'am, I could wire it.
No, you
Yeah.
stented from left main to LED, right? In a continuous. And your RI, you accessed it through the stent struts?
Yes, ma'am.
So you would have gone through the stent struts and then did your RI procedure. Did you not want to do your RI procedure before? Because then you would have distorted the left main stent if you went to the RI later on.
I had decided not to go ahead with the RI and the PLV, just do osteal left main to LED and see if the patient had his symptoms and leave him like this, because he was already 87. He is not going to do some heavy exercise or something, anything. He is just like doing his daily routine activities. But after 1 month, there was some questionable angina. So I didn't put a stent. I planned a DEB to PLV and RI, both.
How big was the RI? Because in
2.5.
angiogram it was
2.5. It was big enough. I'll just share the screen again.
No, just show me that RI picture.
Yeah,
Because
just
then
showing.
that question arises. Just show that original angiogram.
Yeah, I'll show.
RI was big and it was very tight, is what I can remember.
It was tight and it was big. Yeah.
So go to the RA caudal or the PA caudal view.
Yeah, this one. Yeah, it is a big vessel.
It's a big
You can see the
vessel and
Yeah,
it's
a big
very
vessel.
tight.
It is basically high OM. You can call it RI, you can call it high OM.
See, your only point is if you stent from left main to LED and then you come back after 1 month, your stent is now, there's a good amount of endothelium also occurring over it. Endothelialization has occurred to a certain amount. Then you dislodge all that. You wire through the stent struts into the RI and then you open that. So you would have had to dilate your stent struts and you would have distorted your left main stent struts to get your DCB across into the RI. That is my point. And we never like to distort the left main stent.
Yes, ma'am, but the RI was not ostial. It was proximal. There was some landing zone. So basically, I did not dilate the stent. A 2 balloon actually passed, and then I used a 2.5 millimeter DEB. Definitely before DEB, I had to do some dilatation for the in the stent
That's
strut.
the point. You would have to do a dilatation because you cannot take a DEB across stent struts without dilatation. It would scrape off all your drug. And the moment you dilate with a 2.5 balloon, the struts of a left main stent, you have distortion. And any time that you have distortion, then you can't get away without a kiss and a pot. That is my point. Because once you distort, then you only have one option. You have to do a kiss and you have to do a pot.
Yes, ma'am, I agree with madam's point. Whenever you do any balloon dilatation at the side branch of a bifurcation, the main vessel stent is pushed. It is pulled in, it's distorted. So either you have to do a kissing or side pots, pot, side pot. So either of the two strategies to restore the anatomy of the left main vessel.
No,
because
so
at that point of time, imaging could have been done in second sitting.
The imaging is
Again, the same thing.
Yeah,
so look,
imaging
even if we don't do a imaging, the moment you distort a stent strut, you will have to restore the anatomy again. That is the only point which I was worried about. So if we were planning to, that ramus was very tight, or the high OM, whatever it is, if you are planning to do it at any time, the best time is before you stent across. You were very right that the lesion was not ostial. It was not ostial. So you would have been able to do it and not come right up to the ostium. So had it been tackled before you went left main to LAD, that would be a point. Also, that is when Dr. Sujata's point comes in, that use two separate stents, one for the mid LAD and one for the ostium, which leaves your bifurcation zone free for any recross which you want to do later.
But if we don't overlap stents and leave behind 5 to 6 millimeter of area in between, that is also plaque driven. So there are very high chances of thrombus formation on that area. And definitely the SAD, the in segment restenosis sets in there.
No, your point is there. See, when we are not using imaging, we are not sure. So we can't be sure whether overlapping is a good option or to stent with two separate stents is better. But then the point comes in that the RI has not been tackled and you would have to go through the stent struts again to that. So the distortion of stent struts comes in. But I think, again, that is another point which we think about retrospectively. We don't think at that time, because at that time our entire focus is on the ostial LAD and the middle.
I plan to leave RI and PLV on medical management only, but definitely after 1 to 2 months, I did that. Did the balloon dilatation only. Deb.
All said and done with this discussion, 2 years after the procedure, patient is safe and is 87. And if he develops the distortion related problem after the 5 years, he will be 93 by this year, by the time. So I think this is okay, acceptable now.
Yeah.
It is a good result.
Ma'am, the point which Josna madam brought in, that if you can't do the right heart cath, LVEDP should be measured. I think at many centers there is a protocol before the beginning of the PTC or any chip procedure, you first cross the aortic valve, take an LVEDP, and then only start the procedure. So it's a very good point and a simplified point.
Yes, that is a point well taken.
Yeah.
True.
Regarding IABP, I would like to know from experts, should we use it regularly in LV dysfunction? Because IABP itself, there are a lot of complications associated with it. If the patient is hemodynamically stable, even if it's LV dysfunction, should we use it regularly or keep it for some specific set of presentation?
So it's usually the first line is always the inotropes, and the second line is the IABP. And in most procedures, if we counsel the patient for an IABP, we keep an access. It's only if the patient requires it that we put it in. Otherwise, if the hemodynamics are allowing us, we usually do the procedure without the IABP, but it's on a standby with an arterial access in place. Because it's an additional cost. Like Dr. Rashi was saying, we always have to worry about cost in India because IABP, putting an IABP in my center costs 1 lakh extra for the patient. So we take an access and we wait. If it's absolutely required, we definitely put it. But if we can get away with just inotropes, maintain the hemodynamics, we don't put it.
Sarita, what we do is they say that you do anything pre. So as we said, just measuring the LVDP and if it is fine, or if we had done the right heart cath, the RF pressures, the PA pressures are fine, then don't put the IBP, just use the access. But if these are high, put an upfront IBP.
An upfront IABP actually in sick patients helps much better. If cost is not a constraint, and the patient is sick, upfront is much better.
Yes, acute MI, cardiogenic shock, you can use that upfront.
Absolutely. So if there are no further comments.
One point, ma'am, I would like to mention. The cost constraint thing, because of the cost constraint only Dr. Rashi could not do imaging. At our place also, because of the cost constraint, we'll end up doing many left mains without imaging, because we also work in the scheme patients also, and there are certain subset of patients where you have to go ahead with the procedure. Bypass is not an option and they just can't afford imaging. So practically on ground reality level, many times we'll end up doing left main procedures also without imaging. So Yojana patients and the scheme patients where it's not available. So I think the end result
Point well taken. Dr.
Yeah.
Seema, point well taken.
Yeah.
We do realize that in our country, we have cost constraints in many of the centers. And even in the centers which are very well equipped, many of the patients still cannot afford, which is why that a large number of patients are still having procedures without imaging. And we have phenomenal operators in India. We have excellent operators in India, and which is why they are still able to give such great results. And we have to remember that before the advent of imaging and before its uptake in India, procedures were being done with great end results without imaging. So not having imaging is not a contraindication to do a procedure at any time. Ultimately, it's the patient and the end result which matters. And I think an operator tackles it best in the way that they can with the armamentarium which they have in their cath lab. Having said that, Dr. Rashi, this has been a great presentation with so many wonderful learning points and a great end result and a safe patient at the end of the day. I want to also thank the expert who were with us today, Dr. Sujata, Dr. Asha, Dr. Gyanti. And I want to thank the discussants who were here with us, Dr. Seema Naxain, Dr. Neelam Kaul, for all the wonderful inputs and all the wonderful insights. It has indeed been a great learning session. And thank you to everybody. And have a good night. Looking forward to catching you again in the next meeting. Thank you so much.
Thank you,
Beautiful
madam.
case done,
Thank
Dr.
you.
Rashi.
Thank you.
Congratulations.
Thank
Yeah.
you.
Great case.
Very well done,
Nice
case.
insights, many nice points taken from this meeting.
Yeah.
Thank
Dr.
you.
Rashi, thank you. That was a great case.
Great case.
Thank you, madam. Thank
You're
you so
right.
much for giving the
And
Lot of
opportunity.
learning points, Rashi. Thank you.
And the adrenaline really runs when you look at a case like this and you say, oh, okay. What am I supposed to do right now?
I'm definitely trying for LVDP in right here, Cat. I'll try to incorporate it
good
in my
points.
practice. Yeah, these are good points.
Yeah.
Bye, ma'am. Good night. Good night, everybody.
Good night.
Good night, everybody.
Good night.